Preeya Gupta with Interventional Mindset. And today I have Dr. Andrew Williams from the University of Pittsburgh, who is going to talk with us today about, all of our glaucoma patients that are lost to follow up. Thanks for joining us.
Thanks, Preeya. Thanks so much for having me.
Yeah. So, I love when you suggested this topic because, we always talk about, okay, the people that are in our chair, the people that we're focusing on and treating, but we forget about all the people that don't come back for whatever reason, right? We didn't cure their glaucoma. They still have glaucoma. So tell us a little bit about, some of the work you've done on kind of why, this is an area that you focused on.
Yeah, exactly. Well, thanks, Priya. And this concept of loss to follow-up in glaucoma really got my attention as a fellow when we noticed patients come back and it had been several years since their last visit. And generally speaking, when that's the case, they tend to do a little worse. And so I got interested in this topic, noticing there wasn't a lot of literature on lapses in care and loss to follow-up in glaucoma. So I started with my mentors at Duke. I was a glaucoma fellow down at Duke, and I worked with Julia Rosedal, one of my mentors, to look at an internal data set to see how do patients at the Duke Eye Center do if they're lapsed in care and go back. We found about a third of patients lapsed in 10 years, and those who came back generally did so worse, progressed, had additional surgery. And so with that information in mind, it showed me that we're onto something with this concept, that there is a lot of lapse in care, and people who lapse in care tend to do worse. So I applied for a grant to look at the IRIS registry. This is a national ophthalmic database collected by the American Academy of Ophthalmology, representing something like 70% of ophthalmologists, so a big cohort of ophthalmic patients. And we wrote a grant, the Research Prevent Blindness AAO grant for the IRIS registry research, and said, hey, we're finding these interesting trends in lapses and follow-up at this single institution study. We want to know what it looks like on a national scale. And so thankfully that grant was funded about 4 years ago, and that gave us access to this national data set of over 1 million patients with glaucoma or glaucoma suspect. And the first thing we had to do is whittle that down. So we kind of put boundaries on primary open-angle glaucoma, looked at about 500,000 patients. And my question was, how many of these patients maintain care? In the study design, we did a longitudinal cohort study. So we looked at patients in the first full year of the data set, so 2014, and the last full year before COVID, so 2019. So over this 5 to 6 year period, I wanted to know how many patients maintain care every year. And importantly, the IRIS registry monitors each patient with a unique ID. So even if patients move to different practices, their follow-up would still be captured as long as that additional practice participates in the IRIS registry. And the bottom line was about half of patients lapsed by over a year at some point over that 6 year period. And, strikingly, 2/3 of those who lapsed in care just never came back. So we're losing about half of our patients. And generally, if a patient's gone for a few years, they're probably not coming back, and we're losing them from care. And the risk factors for being lost to care are our most vulnerable patients. So patients who have no insurance, not a big surprise, sadly, but also patients with more advanced disease. So as glaucoma severity increased, the risk of lapsing over a year without care increased too. And that's striking. I mean, once a year is kind of bare minimum for glaucoma follow-up, which was a very conservative estimate, and even the most severe patients were lapsing. And those who were visually impaired or blind were more likely to become lost to follow-up. So it really showed us this problem of loss to follow-up is widespread and affects vulnerable populations, which led us to that follow-on study to say, well, what are the consequences of lapses in care? Does this actually lead to problems for our patients? So we took a sub-cohort of that data set and said, well, for patients who had at least 2 visits in 2014, so 2 visual acuity measurements, and 2 visits in our last year, 2019, 2 visual acuity measurements there, how many went blind, or what is that prevalence of incident blindness over this time span? And wanted to compare patients who had a visit at least once a year over that whole time period, and patients who lapsed at least 1, 2, 3, or 4 years in the middle. So patients who had a gap in care and did come back. So kind of a minority of patients who lapsed and just happened to come back by the end of the study period. And those results are also pretty humbling. And I will say we don't have visual field data in the IRIS registry. So we define blindness just by Snellen criteria. So we're surprised to get the signal we did because it's kind of a crude measurement of going blind from glaucoma. And we excluded patients with other blinding eye diseases like AMD and some corneal pathology and uveitis, vein occlusion, so other things that may have confounded the picture. So we could try to say as best we can the patients who went blind from glaucoma. We found about 5% of patients went blind in one or both eyes over that time period. And those who were lapsed in care by 3 or 4 years were more than twice as likely to go blind than those who maintained care. So it really shows that, taking care of patients does something. So that's somewhat validating as a glaucoma specialist to say that when a patient's coming to see me at least once a year, that preserving sight. But it also really shows that not only is lapsing in care a big problem and that it's highly prevalent, but it's also highly consequential. And we found patients who lapse in care are really at risk of losing sight, even by Snellen criteria of visual acuity. So really striking results. And I was kind of surprised at how potent they
Yeah.
were.
Yeah, I mean, just thinking about, okay, so you said, being lost to follow up is way more common than we realize.
Yeah.
And if a patient is lost to follow up, they're much more likely to go blind over their time course of having the disease, which just speaks to glaucoma being a progressive disease. And, I always believe that as we get older, their risk of progression increases over time. But, to me, that's just screaming, we as clinicians that are treating patients with glaucoma, if given a choice, I would think based on your data that we should be picking therapies that don't always involve patient compliance.
I think you're exactly right. The data bear that out. So we initially we had this kind of hypothesis going in. There's some thought that, well, if you do SLT on a patient, for example, you may get this false impression that they're cured and they don't come back. But we found exactly the opposite. So patients who had a history of laser trabeculoplasty, SLT or ALT, some sort of laser trabeculoplasty code in the 10 years leading up to entering this Irish registry were actually 20% less likely to become lost from care. So patients who had some sort of intervention, and even other glaucoma surgeries had the same pattern, but having laser trabeculoplasty or surgery early on was protective against loss to follow-up, which may be a reflection of the physician-patient relationship. There may be more to it than that, but for what it's worth, there was less loss to follow-up in the intervention group. And in that follow-on paper, those who had an intervention early on seemed to be more protected from blindness. Now, the confidence intervals get kind of wide, so there wasn't statistical significance, but it seemed like when controlling for other known risk factors for blindness from glaucoma, like age and race and other things, those who had a history of a glaucoma procedure tended not to have a blindness risk from lapsing in care by several years, while as those without a glaucoma procedure had that about twofold risk. So there may be some signal there that not only does early intervention maintain patients in care and keep them invested in their care for their disease, but it may protect those who do lapse in care from going blind. And that sort of kind of dovetails well in the LIGHT trial. So laser
Yeah.
trabeculoplasty compared to medication first, even though IOP is not that different between groups after 5 years, the visual field preservation is much better in the laser group because that's sort of the compliance is built in. The laser's working all the time. The treatment's always going on in the background so that you don't really rely on that day-to-day compliance from the patient nearly as much.
So, the LIGHT study, of course, was done, in Europe and not here. And so is when you have patients in clinic today, what are your interventional therapies that you're sort of starting with?
Yeah, I think the LIGHT trial's been practice changing where not only what I used to say to a patient, if this is a newly diagnosed glaucoma, we could do drops or we could do laser. Now I frame that totally differently because to really practice evidence-based medicine now, it's really not an equivalent option. We know that laser intervention, early intervention is actually better therapy. So now what I say is I recommend a laser first intervention. There's also a drop. And you can probably extend that same line of reasoning to extend to release prostaglandins in different forms. The principle being if we're getting some sort of intervention that's working all the time, the evidence is there that this is better in the long term.
Yeah, I mean, I think that we're just really beginning with our interventional therapies. SLT used to be something that only glaucoma doctors did, and now I think comprehensive ophthalmologists and even look me as a cornea specialist, I do SLT, all the time to try to get people off of medications that might be bothering their corneal surface. Drug delivery is just in its infancy. I agree.
Mm-hmm.
iDose is certainly out there in the pipeline. What's really interesting is Cataract surgery is probably one of the most common surgeries done in ophthalmology worldwide. But there's, some newer technologies. Spyglass Pharma has uh,
Mm.
a bimatoprost eluting implant, has these little pads that elutes drug for, 3 years. And so, I think in the next number of years, we're going to continue to see this kind of exponential increase. And maybe not only because doctors believe in it, but also because we have better technologies that are coming out to provide that sustained release, the sustained IOP control. And I think that's where we are today in this big paradigm shift.
I think you're exactly right. Whether it's a drug-eluting IOL or other long-term delivery options, having a prostaglandin working all the time is I think it's going to be only for the better. Whether, even for patients who maintain regular care, but you can imagine it's especially nice to have that buffer for patients who aren't always able to attend annual visits.
Yeah, and when I think about, okay, like why do patients get lost to follow up? Because that's
Yeah.
another really important area where, whether it's patient advocacy from societies, or just grassroots organizations encouraging eye screening and eye exams, right? People have to get seen in order to have their care addressed. But, I think a lot of times the patients that get lost, we forget about all the side effects of asking a patient to take a medicine. We're assuming they have the manual dexterity. We're assuming they have the mental capacity, especially in our, aging population. There's just a lot of and financial assumptions. We assume that, hey, every time we write an eye drop, that they actually can get it. And so, you know, one of the things I love seeing, and I love ophthalmology. I love we have such an amazing field. But one of the things I've noticed is that when we as surgeons make a recommendation to a patient, our patients can see if we're excited about it or if we're passionate about it or not. And I think when interventional glaucoma kind of started, like, yeah, okay, my glaucoma colleagues were pumped and that was great. But I think, it's just spreading like wildfire that it is meaningful to lead with an interventional procedure. And, not all our patients are going to accept that, but to continue to have that like reintroduction so that in case they fall into that, god awful percentages that get lost to
Yes.
follow up,
Right.
there's something going on in the background.
Yeah, exactly right. And it's also exciting to be able to have these options to patients when someone does come to you and say, what if this doesn't work, doc? Or what would be your next step if that laser doesn't take? Could it be repeated? Is there something else you can try? And it's nice to have more and more tools in our toolbox to be able to help our patients. Maybe the extended prostaglandin makes more sense for one patient and SLT makes sense for another. If you have a patient with cataract and glaucoma, that really opens a window to additional intervention. And it really is a nice surprise to a lot of my cataract patients with glaucoma to say, not only can we take out the cataract, but we can do something at the same time to get you off those 2 drops. And it's nice to be able to do these things for our patients without committing to a filtering procedure or tube or a trab to be able to work. The enhance the natural outflow procedure, act early in mild, moderate stage disease to really help give our patients the best chance of maintaining sight.
Yeah, I mean, I like to describe glaucoma to my patients as like the seasons of glaucoma. It's a disease that rarely stays the same for your entire life.
Mm.
We hope it does, and we hope it doesn't progress. But sometimes, it's whatever works for right now might not work later on, and it's the stepwise approach. But coming for your eye exams and keeping your appointments is a big part of that. So I think I'm just excited that you could share your work today and bring awareness to this important topic. And any last thoughts?
Well, I think, the biggest thought I had lingering after, well, first, thanks for having me and being able
Oh,
to
of
talk
course.
about all these things. But, when I see these results and think, wow, this is a big problem. Wow, this is a consequential problem, these lapses in care and loss to follow-up, think, well, geez, what can we do about it? What can we do as practices, as society, as ophthalmologists? And I think, simple things would be reminder messages and phone calls. So if at the end of the day you have your no-shows, which we all have, no-show is a strong risk factor for loss to follow-up. If we could say, all right, these are the patients who missed their appointment today. Maybe these patients I'm particularly worried about, could we give them a call and reach out to patients? And we ran sort of separately a clinical trial here at the University of Pittsburgh where we took all of our patients who had a no-show and randomized them to a message that day or usual care, which is a letter in the mail a week later. We found that sending a message right away, that fresh moment, maybe fresh on their mind, just missed your appointment, we want you to reschedule. We noticed you were gone. These appointments are
Yeah.
important, and that led to doubling the rate of reattendance of an appointment within 30 days. So
Yeah.
that's sort of low-hanging fruit. The reasons for missed appointment, when we ask patients, are often forgetfulness or conflicting demands, but being able
Yeah.
to put that back on their radar can go a long way. And also asking patients if they need help. This is a trickier thing to do at a practice level, perhaps, but we know that for those who have trouble making their appointments, one common reason is transportation needs, and there are other health-related social needs that we really should do a better job asking about. And if we screen patients for these needs or connect patients with the resources, so get social work involved early, that can go a long way because there are a lot of benefits that patients qualify for but don't necessarily know about. Transportation programs through Medicaid and other things. And we found just anecdotally with a patient navigator, it works a lot like a social worker in our department, connecting folks to resources to maintain care has made a big improvement for patients who otherwise really wouldn't be able to make visits or attend outpatient surgery. So I think one thing I kind of took away from the IRIS registry work is it's a big problem, and the things we could probably try to do to chip away little by little. This is a big scope. Half of our patients are being lost from care within a 6-year period. That's a short amount of time that a patient has glaucoma. Any little bit might help. But, my thought is glaucoma's tricky. About half of patients with glaucoma don't even know they have it. And now we're talking about the half that know they have it and have seen a doctor, and we're losing half of those. So if we can do, little by little to keep those patients in the fold and help them maintain care, I think phone calls, reminder messages, social needs screenings might be one way to do that. On top of course, early intervention, helping maintain care and keep that long-term IOP lowering delivery going in the background. So both the social needs side, the intervention side, I guess that's what doctoring is all about, that whole person
Yeah.
and thinking about the course of their disease.
That's amazing. Very well said. Thank you so much for joining today. We really appreciate all of your insights.
Okay, thank you so much for having me, Preeya. I appreciate it.